Hello everyone and welcome to this live Springer Medicine webinar. I'm so excited to be hosting this webinar on such an important topic and with such an excellent speaker, and I'm delighted to have you all with us. So I'm Natalie Wood and I'm Senior Clinical Content Manager at Springer Medicine. So for anyone who's just discovered our platform, we're an international educational site for clinicians. We're covering a breadth of clinical specialties and we provide cutting-edge clinical education for specialists in a variety of formats, which we highlight in regular newsletters that are curated just for you. So our aim is to keep you up to date with your practice and by providing content such as this webinar. So today we are shining a spotlight on the insulin toolkit for type 2 diabetes. So for more than 100 years, insulin has been the cornerstone of therapy for people with diabetes. And during that time, there have been many advances from purification to engineering and delivery. So excitingly, the evolution of insulin now continues with the arrival of once-weekly insulins that promise to reduce the burden of daily injections. But how do these therapies fit into modern care pathways for people with type 2 diabetes? And what other benefits do they have? How should they be introduced to insulin naive and insulin experienced patients? And what are the barriers and challenges that need to be overcome? Thankfully, I know we're in a great position to understand all of this and more. Our speaker today is Dr. Alice Cheng, an endocrinologist at Trillium Health Partners and Unity Health Toronto, an associate professor at the University of Toronto in Canada. I was lucky enough to hear her speak at the EASD conference last September, and I can't wait for you to hear what she has to say. So the plan is for Dr. Cheng to speak for around 45 minutes, and then we'll open up to questions from the audience. So now, without further delay, I am delighted to hand over to Dr. Cheng. Welcome and thank you for being with us today.
Welcome to the audience as well, and thank you for choosing to spend the time with us today. So before I begin, I thought I should start with my disclosures. I have worked with many different diabetes and cardiovascular companies, but primarily in the form of education or in the form of consulting. And as Natalie has already mentioned, these are the learning objectives that I hope we'll be able to achieve over the next hour. So after this webinar, I'm hoping that you'll be able to describe the shifting approach to insulin therapy, particularly for type 2 diabetes, from the daily to the weekly options, to address the insulin needs of those who are insulin naive as well as those who are insulin experienced, and to discuss the pros and cons of once weekly basal insulin treatment and communicate these effectively with your patients. But before we dive into insulin specifically, I think we need to place insulin in the entire holistic approach that we now have for the treatment of type 2 diabetes. And I always want to start here because it's a reminder of this beautiful circle of care. This is how I like to call it, from the ADA and the EASD. And what I love about it being a circle is that circles have no beginnings and have no ends. It is a circle. So we are to close the circle in people living with diabetes. And the central components of the circle are shown here. We need to be utilizing cardiorenal protective therapies when appropriate, which is frankly most of the time, and namely those are SGLT2 inhibitors and GLP-1 receptor agonists for their organ protecting properties, irrespective of A1C, irrespective of the use of metformin. We should also be achieving glycemic targets for reasons that hopefully are well obvious to this audience in terms of reducing both microvascular and macrovascular complications. We also have to achieve weight targets. Targets is perhaps not the right term to use, but rather consider weight management in the holistic person-centered approach to type 2 diabetes management, and therefore preferentially selecting therapies that are going to be more favorable from a weight perspective. And then, of course, we still need to address all the other cardiovascular risk factors, including blood pressure and lipids and use of organ protecting other therapies that are non-antihyperglycemics like ACE inhibitors and statins and aspirin, icosapent ethyl, et cetera, et cetera. So it's within this context of closing the circle that insulin certainly still has a role, particularly in this quadrant of trying to achieve glycemic goals, which are still important. It's not as if we've thrown out glucose control, given all of the other fantastic tools we have to help our patients. We still absolutely still need to achieve glycemic goals, and that's where insulin fits in. Insulin is listed as one of the very high efficacy options we have to help people achieve the glycemic goals that we know are important. Now, if we think about the place of insulin, and this is again taken from ADA and EASD, I want to direct your attention first to the top left. So looking at the top left, there are some individuals where we must go to insulin right away from the beginning. And these are individuals with severe hyperglycemia, any kind of metabolic decompensation. In other words, we're suspecting that perhaps they're not making enough insulin and maybe more type 1 than type 2. And those individuals, we absolutely start insulin from the get-go, and we still implement those other 3 quadrants within that circle of care. But for most individuals, though, they do not fall in the top left. They're sort of more in the top middle, where we should be using as the first injectable a GLP-1 receptor agonist if we're using it as an injectable. And then it's only as we go down the algorithm if someone is not able to achieve their personalized A1C targets despite use of a GLP-1 and often an SGLT2 inhibitor and perhaps other therapies, then insulin absolutely still has a role. And typically when we initiate insulin in the type 2 diabetes space, we tend to recommend starting with basal insulin for a variety of reasons, but it's an old study, it's an oldie but a goodie. So an old study called the 4T study actually asked the question in type 2 diabetes, what is the better insulin start? Is it a basal insulin start? Is it a bolus insulin start? Or is it a premixed insulin start? And the basal insulin start did work out better in terms of less weight gain and less hypoglycemia, although eventually people ended up requiring some addition of bolus insulin, as is depicted in the rest of the algorithm as you go down, is after starting basal insulin, if no longer able to achieve targets, then the addition of other types of insulin. So basal insulin absolutely still has a role in the management of type 2 diabetes. So if we now focus in on the basal insulin space, as that is where we typically start in type 2 diabetes, it's always nice to sort of look back in history and see how far we've come. I'm speaking to you here from Toronto, which we still like to refer to as the birthplace of insulin, or at least the birthplace of clinically used insulin for the treatment of diabetes. And sort of the original insulin, quote unquote, islatin, and then the advancement of protamine and zinc insulin to sort of prolong the action. And then 1946 was the development of NPH insulin, which we still utilize, which allowed the insulin action to again be protracted. And then there was Lante insulin, which was then removed. And then it took about 50 years to see the next big jump in basal insulin therapy advancement, which was the development of insulin analogs. So we had insulin glargine U100 and insulin detamere representing the first generation insulin analogs, which allowed for longer, flatter action. And then thankfully we didn't have to wait 50 years. It was more another 15 years to then get the second generation basal insulin analogs with glargine U300 as well as insulin degludec. Now, if we think about how these different insulins play out in the time action profile perspective, this is a nice cartoon figure from a recent review article where you have plasma insulin levels on the y-axis, you have time represented on the x-axis, but that first bit is still just representing a single 24-hour period. And then the latter bit of the x-axis is representing weeks. So there's a slight change in that x-axis. But starting with the yellow insulin, which was NPH, human insulin, wonderful for its time for protracting the action of insulin available then, you can see that it still had a peak and it was still relatively short to be a true basal. Then we got the orange and the blue insulin, which was detamere and glargine U100, which was our first generation basal insulin analogs that were longer and closer to the 24-hour duration. Then we got the purple and the red insulins, which were the second generation basal insulin analogs, which really stretched out and went beyond 24 hours in terms of its insulin action. And now we're in the era of the dotted line, which is the weekly insulins, which have a much more protracted half-life and therefore able to be taken once weekly. And all of this movement in the basal insulin space is to flatten out the pharmacokinetics, to reduce the variability and ultimately reduce the injection burden for the individuals needing to take basal insulin. But if we think about how these insulins work, so I'm going to take you back a little bit in history because we may have forgotten how these insulins work. First thing that we need to remember, though, is that insulin in circulation is insulin, right? So therefore, IV insulin, we typically give the quote-unquote short-acting insulins, but in the blood, insulin is insulin is insulin. So therefore, how do we get very fast-acting and medium-acting and long-acting and really long-acting insulins is by changing its behavior in the subcutaneous space so that it's absorbed at a different rate, or its interaction with the insulin receptor so that it's interacting at different rates. So that's how it's actually being done. So with that principle in mind, let's go back to the first generation basal insulin analog, starting with glargine U100. How did it work? Well, it worked by the creation of it such that it would precipitate into microcrystals in the subcutaneous space based on the different pH. So based on the different pH of the human body versus in solution, it would then microcrystallize, and then those crystals would slowly melt, if you will, into monomers, which would then allow it to then be absorbed into blood and therefore act as insulin should act, which therefore allowed for the red line, which in this case is representing glargine U100, to be a flatter, longer insulin compared to its previous human counterpart of NPH. That was first generation glargine. Then we got second generation glargine U300, and an interesting phenomenon was that the act of concentrating glargine changed its behavior such that the crystals that were precipitated in the subcutaneous space became tighter. So tighter crystals that melted slower. And by melting slower, you then protract that time action profile. And here in the bottom graph, we're actually depicting glargine U300, the second generation, in red compared to first generation, and you can appreciate flatter and longer. And it did it just by making tighter crystals that melted slower. Now let's move on to insulin detamere, a first generation basal insulin analog. So the way insulin detamere did it was that in solution, it was a hexamer, and then upon injection, they formed dihexamers, so two hexamers stuck together, and those slowly dissociated over time into monomers. And then there was also albumin binding, which was another method of protracting its life in the subcutaneous space, if you will. And then that's what then allowed insulin detamere to have a flatter, longer profile than insulin NPH, the human version prior to that. And if we compare the two first generations, glargine U100 with insulin detamere, you can see that they were certainly compared to NPH, flatter and longer, but compared to each other, there were some subtle differences in that glargine U100 looked a bit flatter and a bit longer. Then we had second generation basal insulin analog, another one, which was insulin degludec. Insulin degludec utilized, again, dihexamers in solution, upon injection, multi-hexamer, so like a choo-choo train, I like to think of it. And then in the subcutaneous space, the choo-choo train would slowly disassemble into monomers. And then there was also albumin binding, creating another reservoir of insulin available for use, which then allowed for another second generation basal insulin analog. And here, when you compare the two second generation basal insulin analogs, you can appreciate they're very similar with some differences in terms of flatness and in terms of duration, but both certainly being better than the previous generation for being flatter and longer. So that is how these four insulins were allowed to protract their time action profile, which then brings us to the once weekly basal insulin. So we have insulin icodec, insulin efsitora alpha, insulin icodec available for use in many countries already, insulin efsitora alpha already undergone a very extensive clinical trial program, and we're waiting for it to become commercially available. So these are the two once weekly basal insulins that we primarily discuss. And the way they protract their action and allow for once weekly administration are different but yet there are some similarities, as I will show you. So starting off with insulin icodec on the left-hand side. So you have the insulin molecule with the 2 chains with some amino acid modifications, a spacer that was attached, and then an attachment to the C20 fatty diacid, which then has a strong role in its prolonged action. I'll come back to insulin efsitora shortly. You can see the half-lives on the bottom, much more extended compared to the second generation basal insulin analogs. So if we think about insulin icodec, it's a weekly administered insulin. So at first injection on day 1, let me just orient you to this figure. First off, the blue, these light blue circles, if you will, represent the insulin icodec. This first segment is the subcutaneous space. Here you have the blood vessel. Here you have the intercellular space. And then this yellow stuff on the bottom represents the cellular space. Obviously, not all of this is to scale. The blue blobs represent icodec. These gray blobs represent albumin. So now you've sort of gotten all of the players that you need to get. So with the first injection, day 1, you can see that there's a deposit of insulin icodec in the subcutaneous space, and some of it is going into the blood vessel and binding to albumin, which is a major source of the reservoir of insulin icodec, but that's after the first injection. And then after the second injection, 48 hours after the second injection, you're seeing more of the icodec, the blue icodec, being incorporated into the blood vessel and now into the intercellular space and starting to interact with the insulin receptor on the bottom. And then when we reach true steady state, which is after the 4th or 5th injection, then you can appreciate you're now reaching an equilibrium between the insulin icodec in reservoir attached to albumin, and then it's binding on and off of the insulin receptor. So taking about 5 half-lives to reach steady state, as we would typically expect with something with an 8-day half-life. And therefore, we see that when it comes to glucose lowering effect. Let me just orient you. First of all, the light shaded gray line, this up and down roller coaster in the background, that is referring to once daily insulin glargine U100. The x-axis is in weeks. So you can see it's up, down, up, down, up, down, because it's a daily injected insulin. Now I want you to pay attention to the dotted line. The dotted line represents once weekly insulin icodec. So after injection number 1, you get some lowering effect. Injection number 2, you get some more as the icodec accumulates. Injection number 3, more accumulation of the icodec, and then starting to achieve that equilibrium for the on-off of the insulin clearance, and then injection number 4, and so on and so forth. So what you can appreciate, it takes about 4 to 5 injections to reach that steady state. So therefore, one way to make it faster would be to do what the bolded dark line represents, which is to give a loading dose. You give an initial higher dose in week 1, so you load the system in the front at the beginning, and then it won't take quite as long to actually reach steady state. So you can appreciate then the difference between loading and not loading, which is the dotted line versus the dark line. And when steady state is achieved, in the case of insulin icodec, this is what the glucose looks like, area under the curve looks like for days 1 through 7, with a little bit of a higher effect, glucose lowering effects in days 2 and 3, and then a slow reduction as we reach day 7, but very small differential. So that's insulin icodec. Albumin is its primary ability to create that reservoir. Now, in contrast, let's look at insulin efsitora alpha on the right. Very different. Insulin efsitora alpha is probably better described as an insulin receptor agonist, which I guess technically insulin is as well, but it's a very much more designed insulin, if you will. It takes a novel single chain insulin variant and then links it, and then attaches it to an IgG-Fc domain, which then changes its time action profile and also improves its stability as well as the ability to manufacture it. So what this very different molecule does and how it creates a reservoir is shown for you here. So again, let me orient you. So you have the subcutaneous space up here on top. You have the blood vessel. You have the intercellular space in this beige zone, and then down below that would be the cellular space. These what look like paper clips are in fact the insulin efsitora. They look like nose clips, actually. These nose clips are the insulin efsitora, and then you have the insulin receptors shown here in the purple. Now, what's happening in the case of insulin efsitora, the ability to build the reservoir has nothing to do with albumin. It's actually doing it within the endothelial cell. So this is now a blowout of the endothelial cell. What happens with insulin efsitora is here's blood in the red on the outside, and then when it goes into the endothelial cell, it will attach, because of the Fc domain, to the neonatal Fc receptor. And in the acidic environment of the endosome, it is protected from degradation. And then there's a recycling system, like many things in biology, and upon its recycling of the endosome back to the cell surface, let me go back to the cell surface, the different pH of the blood then allows for dissociation to occur. So instead of albumin binding, as we see with insulin icodec, insulin efsitora creates the reservoir within the endothelial cells by protecting it through the Fc receptor binding in the endosome, and then there's a recycling system that's occurring where it's being brought in, it's being protected, and then when it comes out, then it dissociates and can do its job. So this is a slightly different method of creating that reservoir of insulin. So in the case of insulin efsitora, this is what it looks like with injection number 1, mostly in the subcutaneous space, a little bit in the blood, and slowly trying to get into the intercellular space. And then with injection number 2, you have accumulation, more efsitora, more diffusion into the blood vessel and intercellular space, injection 4 and injection 8, when the equilibrium is in fact achieved. And in the case of insulin efsitora, we have a similar concept, and now this is again weeks on the x-axis, but just more weeks represented, 12 weeks represented. The light gray represents daily insulin, and then the dotted line represents once weekly insulin efsitora, where there's no loading. So again, it takes about 4 to 5 injections before you start to get closer to where you want to get, and then probably closer to 8 injections to fully get where you want to get. And then if you load, which is the dark bolded line, you can get there faster. So that's why in both cases of basal insulin that's once weekly, you will hear about the concept of a loading dose just to achieve the glucose levels at a faster rate. So now when we think about the once weekly basal insulins, we've gone a lot into the mechanism of action, because I think it's always interesting to see how really smart people actually design these things. The similarities between them, their once weekly administration, both of them, which I forgot to mention, have a reduced insulin receptor affinity. Now, initially you might think of that, well, I don't think that that's a good thing. I thought you'd want high insulin receptor affinity. But in both of these cases, they have reduced insulin receptor affinity, which therefore means you have to have enough load of insulin, or in the case of insulin efsitora, sort of the insulin receptor agonist, in that intercellular space before you then work on the insulin receptor. So then it's sort of another method of slowing down its action, if you will, is by reducing the insulin receptor affinity. Both cases, you need multiple injections to get to steady state, and in both cases, a loading dose is helpful to reach that steady state faster. Where's the difference? The big difference in my mind is that the mechanism to achieve that reservoir of insulin is different. In the case of insulin icodec, it's through albumin binding. In the case of insulin efsitora alpha, it's through the Fc receptor binding. So all that is well and good and fun and interesting, hopefully, for you to have learned or to have reviewed in terms of how these different insulins do their thing, but what do the clinical trial data show us? So let's start off with insulin icodec. So in the case of insulin icodec, it's the Onwards program, which is their phase 3 program. And these are just, it's a summary of the top line results for the various studies. So in the insulin icodec program, Onwards 1, 3, and 5, we're looking at people naive to insulin. And then Onwards 2 and 4 were people experienced with insulin in the type 2 diabetes space. And then Onwards 6 on the far right is in type 1 diabetes, and I will not be speaking as much about that particular group. In the case of A1C being the primary endpoint for all of these studies, non-inferiority is confirmed across the board compared to a daily basal insulin comparator. And then in case of superiority, in a few of the studies, superiority was confirmed, although the magnitude of difference in A1C was around 0.2, 0.3%. This would be sort of the high-level summary of the Onwards program. If we take a closer look now, that was for A1C. What about for body weight? From a body weight perspective, the basal insulin and the daily comparators were generally comparable when it came to body weight changes. The only exception was Onwards 2, which was a basal switch, where there seemed to be a greater weight increase in the insulin icodec group, but a delta of about 1.7 kilograms, so really quite small. And then for hypoglycemia, which is probably the biggest question that comes to mind, when it came to level 2 or 3, so clinically significant or severe hypoglycemia, there was really no appreciable difference between insulin icodec once weekly versus the daily comparator. When it came to level 1 hypoglycemia, though, there did appear to be a little bit more level 1 hypoglycemia with the weekly insulin. And I'll call your attention to Onwards 4 and 6 on the right-hand side. Onwards 4 was still in type 2 diabetes, but there it was basal bolus insulin. And you can see that much more hypoglycemia was seen, but that's because of the bolus insulin part. And critically, there was no difference, though, between icodec and glargine U100. Type 1 diabetes, though, I think is a different story, where there definitely did seem to be more hypoglycemia, clinically significant and severe in the group receiving weekly insulin compared to the daily, and that probably has more to do with the titration schedule. So I think we still have a lot more to learn in the type 1 diabetes space. But in the type 2 diabetes space, as efficacious for A1C lowering, and in some cases a little bit better, with no difference in clinically meaningful or severe hypoglycemia between weekly icodec and daily comparator. What about for insulin efsitora? So for insulin efsitora, their phase 3 program was called the QUINT program. And here again, they looked at insulin naive individuals as shown in QUINT 1, QUINT 2, insulin experienced individuals with type 2 diabetes in QUINT 3, QUINT 4, and then QUINT 5 was their type 1 diabetes study. You can see on the far right of this table, the comparator insulin, which of course would be a daily basal insulin as the comparator. Now, when I show you the data for QUINT trials, I'm actually going to start off not with the insulin naive, I'm going to start off with the insulin experienced group, so QUINT 3 and QUINT 4. The difference here is that QUINT 3 was strictly basal insulin. In QUINT 4, it was those on basal as well as bolus insulin. So let's start off with QUINT 3. So QUINT 3 is a study of insulin efsitora versus insulin degludec in insulin experienced individuals, but only on basal insulin, no bolus insulin component. Red is efsitora, blue is insulin degludec. Bottom line, non-inferiority demonstrated, and both insulins are efficacious insulins to lower A1C in people who needed more A1C lowering. The bottom figure gives you the CGM data at baseline, week 26, week 78 for the two groups, efsitora first, followed by insulin degludec. And what you can appreciate, again, both insulins improved time in range, as shown in the green, and the amount of time below range, which is the very, very bottom, the yellow and the red, very, very small with no real difference between the two insulins. So both basal insulins effective, and of course weekly has the advantage of being weekly. What about QUINT 4? So QUINT 4 was the study, similar design of efsitora versus a comparator, in this case daily glargine U100, in those who were on basal bolus insulin. And here you can appreciate, again, efficacy-wise for glucose lowering, equally good. And then looking at CGM on the bottom, also equally good, but more hypoglycemia experienced in this study because of the bolus insulin component, which was not there in QUINT 3. So summarizing the insulin experience, among the insulin experienced people with type 2 diabetes with or without prandial insulin, insulin efsitora compared to daily basal showed non-inferiority for A1C, as well as similar rates of hypoglycemia. So good news. What about in the insulin naive space? So in the insulin naive space, there were two studies. There was QUINT1, QUINT2. Let me talk about QUINT2 first. So QUINT2 was typical study, weekly basal insulin versus a daily comparator, in this case, insulin degludec. And here you can see again, efficacy as shown on the top left panel for A1C reduction, very similar and very effective, getting from an 8.2 baseline down to 6.9, let's say baseline, 6.9 at 52 weeks. And then when you look at the CGM data on the right-hand side, a marked improvement in time and range with the addition of basal insulin, and weekly was as good as daily. For hypoglycemia, shown on the table on the bottom, if you just look at the estimated rate ratio on the right-hand side, you can see that the numbers cross 1, so there did not appear to be any difference, certainly for clinically significant or severe hypoglycemia. So again, the basal insulin appeared to be safe compared to that of a daily. The study, though, that for me in the efsitora clinical trial program that I think is most exciting is actually QUINT1. So QUINT1, again, looked at the insulin naive population, but the design was unique in that instead of doing a typical insulin titration that we're all used to, where we titrate weekly on the basis of the fasting glucose, here there was fixed dose titration of the weekly basal insulin efsitora in this case, compared to classical titration of daily glargine U100. So a very novel and different concept in the insulin space where we haven't done fixed dose titrations, but we do in other spaces, right? If you think about our GLP-1, in the case of semaglutide, we go 0.25, 0.5, 1, 1.7, 2.4. Like there's fixed dose titrations in other areas, but not typically in insulin. So here they thought they would try something different. So first dose of 100 units, and then if the fasting glucose was still above the target, then you would go to 150 units. And then if 4 weeks later you were still above target, you went to 250 units. And then if still above target, you went to 400 units. And then 4 weeks later, if still above target, then you had the variable dosing. So perhaps an easier algorithm for introduction and titration of weekly basal insulin. And you can see the percentages of people at week 52 were on the different levels. And what you can appreciate is that most people did not need to go up beyond 400 units. And in fact, a lot of people were able to achieve success at these lower levels where there was just this step up of 100 to 150 to 250 to 400 and then beyond. But did it work? And the answer is it did work. So the red line is efsitora, the gray line is insulin glargine, and you can appreciate that at the 52-week mark, the two insulins were equally effective in terms of getting people's A1Cs to similar levels. The timing in those first 4 months may have been a little bit faster with glargine and a more classic titration. The efsitora may have been a little bit slower to get where it needed to get, but it ultimately got where it needed to get. And then from a hypoglycemia perspective shown on the right, you can see that the rate ratios all crossed 1. So really no appreciable difference between the fixed titration versus classic titration with the daily. So if we think about the clinical trial data in totality, this would be the summary. So insulin icodec was non-inferior or in some cases superior to daily basal insulin, with no increase in clinically significant or severe hypoglycemia. In the case of insulin efsitora, it was non-inferior to daily basal insulin with no increase in clinically significant or severe hypoglycemia. QUINT1 shows that a fixed dose titration may actually be an option for efsitora in insulin naive type 2 diabetes. And I would say, even though I did not show you the QUINT5 data for efsitora, it was very similar to that of Onward 6 with insulin icodec, where in the type 1 space, I think we still have a bit more to learn in terms of how best to titrate and dose weekly basal insulin, because it was associated with more hypoglycemia for the weekly basal insulin group. But of course, the most important difference between these two is that you get 1 injection a week versus 7 injections a week. And in terms of person-centered care, I think that very much speaks to people living with diabetes. So with that background of the mechanism as well as what the clinical trials have shown us, now let's get down to brass tacks, as the expression goes. Let's get to practicalities here. And when it comes to practicalities, these insulins are quite different in terms of their dosing and their titration. I will focus my attention on insulin icodec for the remainder of the presentation, really just because this is the one we have to play with at the moment. And insulin icodec is the one, certainly in Canada, I think we were perhaps the first country to have actually gotten insulin icodec commercially available for use. So we've certainly had a lot of experience now with the use of insulin icodec. So the first question is perhaps, well, who is the appropriate patient for us to be considering a weekly basal insulin? Well, I think it's actually any new start now. Any new basal insulin initiation in type 2 diabetes, it makes sense to offer the weekly as opposed to offering a daily for the simple issue of convenience and burden on the patient. Much easier to talk them into 1 injection a week than 7 injections a week. Very similar to what we did with GLP-1s. We all moved to the weekly GLP-1s when they became available because compared to a daily GLP-1, not sure from a patient discussion, it's easier to talk about weekly. And then even for current basal insulin users, currently on a daily basal, I think they need to have a conversation and be aware that a weekly option is available and see if they wish to have a switch. But in whom will I not use it yet? For now, again, this is my opinion. I personally have not been offering it in type 1 diabetes, but if someone asks, obviously we'll have that conversation. And that's because I don't think we yet fully know the best way to titrate in type 1 diabetes. And there was more hypoglycemia in both of the studies, certainly in that initial phase. So I think in type 1, I've been holding off for now. We also have other fantastic tools in type 1, like automated insulin delivery. And then for those who are planning pregnancy or is pregnant, we simply do not yet have the data for these 2 insulins in the pregnancy space. So let's talk about practicalities around initiation and titration. And remember, it's easy to start, but then it's all about titration. Because if you don't titrate, you might as well not start because people will not achieve goal. So we have to start, but then we also have to appropriately titrate, which means getting to target efficiently and safely. So if we think about insulin icodec for the insulin naive individual living with type 2 diabetes, it's easy to remember. We typically start daily basal at 10 units. So it's 10 times 7, which is 70. So we would typically start with 70 units once a week of insulin icodec in the insulin naive type 2 diabetes population. Just as we do with daily basal insulin, you're going to individualize. And depending on your level of comfort with insulin, you may kind of look at that patient and go, yeah, I wouldn't have started with 10 daily. So then whatever you would have started for their daily is multiply that by 7, and that would be your starting dose for the weekly. How do you titrate? You titrate on a weekly basis, so once a week. This is what was used in the clinical trials based on the mean of the previous 3 fasting glucoses. The icodec was titrated up or down by 20 units, which on the icodec pen is 2 clicks, because each click is 10 units. So it's up or down 20 units based on the fasting glucose. Now, what if you have an insulin experienced patient? You have somebody who wants to switch to a weekly basal insulin. Well, then in week 1, the recommendation is to do a load. We can talk about to load or not load, but in week 1, the typical recommendation is to do a load because they're already on daily basal insulin. We want them to at least maintain the control they currently have while you continue to titrate. And because it takes several half-lives to reach steady state with such a long-acting insulin, the load allows one to reach that steady state faster. So if they are currently on, for example, 24 units of a daily, then you multiply that by 7 to get the weekly dose. And then the load is an extra 50%. So 1.5 times. So in this case, it's 24 times 7 times 1.5. And then we would always round it to a 10-unit increment because the clicks are 10 units. So this works out to 252. Well, I cannot give 252, but I can give 250. So then that first dose is 250 units. But then starting week 2, they go back to the current basal times 7 without the load, which works out to about 170. So week 1 is 250, and then week 2, they go back to 170. And then starting week 3, the titration begins. And the titration is still that up or down 20. So do you have to load? Well, that's a personal decision between yourself and the person living with diabetes. If you do not load, you know that they will have higher blood sugars for the first few weeks until they come down. But then if you load, then they'll be able to maintain the level they're at a little bit faster and reach steady state sooner. So it's entirely a decision between yourself and the person living with diabetes. The algorithm for titration is the same, whether they're a new person or a switcher. It's plus or minus 20 units based on the fasting glucose prior. So now let's talk about some frequently asked questions. Because one of the big questions that gets asked was, okay, well, this is a weekly insulin. So what happens if I miss a dose, or what happens if I double a dose by accident? So to understand that, I think we need to understand the concepts of peak and trough when it comes to insulin, and we can illustrate it better looking at our older insulins and appreciate that peaks and troughs are far wider apart the shorter acting of the insulin. So on the left-hand panel, top there, you have a rapid acting insulin, which has a 1 hour half-life. So here, the peaks and troughs, just regularly taking that insulin, are going to be far greater because it's a shorter acting insulin. The basal insulin panel on the right, you have a 6 hour half-life insulin depicted in the blue, 12.5 hour insulin depicted in the middle, and a 25 hour half-life insulin like insulin degludec or glargine 300 depicted on the far right. You can appreciate that even though they're being administered daily, that the peaks and trough, the distance between the peak and trough is lessened as the half-life of the insulin is larger. So this is when it's being taken regularly. What happens when you miss a dose? So when you miss a dose in the rapid acting insulin, you can appreciate that there's a far greater dip. And then as we go across the spectrum of the basal insulins, the longer the half-life, the less of an impact a missed dose has. Think about thyroxine. Thyroxine has a 7-day half-life. If someone misses a single dose of thyroxine, usually no big deal, they don't even notice it. But they miss it every day for an entire week or 2 weeks or 3 weeks, then we start to miss it. But because of the long half-life, we don't tend to miss a single missed dose. And you can see that visually here. And this is with a 25 hour half-life medication like glargine 300 or insulin degludec. Now imagine if it's a weekly, an even longer half-life, then that's noticing that missed dose would be less. And then what about a double dose? So here you can see the double dose difference for a short-acting insulin and then progressively longer-acting insulins, where again, the feeling of that doubling dose is less the longer the action of the insulin. So what do you do if you miss a dose? This is what it officially says. If you miss the dose within 4 days from when you missed the dose, then just go ahead and take the dose when you remember and then go back to your usual day. So normally it's a Sunday administer, they forgot the next Sunday, but they remember by Wednesday, then they take it on Wednesday, and then they go back to Sundays. However, if it's longer than that, they normally take it Sunday, they missed it this Sunday, they remember it on Thursday, so it's now longer, then the next dose becomes Thursday again. And the reason is because the Thursday to Sunday dose, that following third week, might be a little bit too close. So the idea is to just extend it out. And then what if you double a dose? So that clinical study was actually done, both a doubling as well as a triple dosing. And what was reassuring was that there was no severe hypoglycemia following double or triple dosing. And there was no increase in overall risk or prolonged duration of hypoglycemia. But if a double dose does occur, then just skip the next scheduled dose and then go back to the usual. So again, pretty logical and not too concerning. What about the duration of hypoglycemia? Is it longer because you're on a longer insulin? And the answer is no. So these are CGM data from the Onwards program, and it's about 35 minutes-ish of duration of hypoglycemia, whether you're on a daily basal, like glargine in this case, or insulin icodec. So it's not extra long for a weekly insulin. And then for the insulin experienced groups in Onwards 2 and 4, again, very similar. 35, 40 minutes is sort of the ballpark, and with no real major extension when looking at insulin icodec. What about an unplanned hospitalization? So in the case of an unplanned hospitalization, number one thing is tell your patient to tell the hospital that they're on a once weekly. because once weeklies are growing in terms of use, but still most commonly used is daily. So the hospitalist is unlikely to have seen a weekly insulin. So it's critical that the patient say, no, this is a once a week insulin. So my 120 units is once a week. So do not order me 120 units of daily. So that's number one, critical. And then they can just keep to their usual schedule. So if they normally take it on Tuesdays and they get admitted on a Wednesday, then they would still, if they can, take their next insulin on the Tuesday. However, if they cannot, then they do not immediately transition to daily basal because the weekly is still sticking around and it'll still be sticking around for 2 to 4 weeks. So in that case, just watch the sugars and introduce the daily basal insulin if that's what you have to use in hospital as the sugars creep up. What if they are going to go for a colonoscopy or they're going to go for an elective surgery? What do we do there? Generally speaking, no dose adjustment is needed because if we've truly used the basal insulin as a basal insulin, then you should be able to fast and not have hypoglycemia because it's just a background insulin. So dose adjustments usually not required. Surgeries, procedures, ideally in the morning, like we typically would advise for those living with diabetes. They should have IV dextrose available just prior to the procedure. So as needed, if hypoglycemia occurs or hyperglycemia occurs in the case, then having some IV insulin available, but not necessarily running depending on the situation. And then just using peri-procedural glucose monitoring to treat glucoses. And then once they're eating and drinking again, they go back to their usual schedule. So I don't think we have to do anything extra different in the case of weekly insulin. So to summarize, and again, a reminder to please submit your questions. Once weekly basal insulin offers a convenient, effective, safe alternative to daily basal insulin. Icodec and Efsitora are the two main ones that we're thinking about. They have different mechanisms of protraction for their reservoir, but they're both administered once weekly. They both have lower insulin receptor affinity, and they both, we think about loading or not loading in both situations. In the case of Icodec, you can see the numbers for yourself as a reminder of how to start and how to titrate for the insulin naive and the insulin experienced. And then in the case of insulin Efsitora, Quint 1 gave us some insight into what fixed dose titration might look like, and that may be something that we think about in the future. So with that, I thank you very much for your kind attention. I will stop sharing and we will open it up for questions.
Thank you so much, Dr. Cheng. We've had a lovely comment in to say how powerful your presentation has been. And so I think, you know, you're getting the message across, and it's great to know that people are appreciating it. While questions are coming in, and thank you for encouraging people to submit questions, we always like to hear from our audience. Perhaps I can just start by asking about your real world experience and what it's been like so far with the once weekly insulins. As you said, you know, you've had the clinical trial data, and Icodec has been sort of approved and available for a little while now. So what has been your experience so far? How's it been received?
So I would say very well, because the insulin conversation has always been a bit more challenging, and we all know that as clinicians, right? The insulin unfortunately carries along with it some stigma. There's definitely still concerns around injection. The injection experience most patients have had is with once weekly GLP-1, so then to have a conversation about a daily injection still doesn't go over that well. So then now that insulin conversation has changed. I bring up the word insulin, people, you know, still have their back up a little bit, and then I say, oh, but it's once a week, and then they're, oh, okay, well then now I'm listening, because that insulin, excuse me, that injection barrier is still very real, despite all the advancements we have in how the injection can be delivered. So it's been very positive in terms of that conversation. The dosing, not an issue. I know when this first came out, healthcare professionals were all freaked out about the numbers, thinking, oh my goodness, 120, that's so big, people are going to freak out. I have not had a single patient freak out. And I think it's because it's pretty logical, right? So for those who don't know insulin at all, they're insulin naive, they also don't know the difference. So what I will tell them though is do not compare your number with your neighbor, because your neighbor's on a different insulin. This is going to be 7 times their number, and that's because it's 7 days a week, and that's all. And then they just nod and go, okay, that's cool. And then for those who are already on insulin, same thing. You're currently on 20. I'm going to start you at 140 because you're only doing it once for 7 days. Oh yeah, okay, that makes sense. Nobody has had an issue. It's us who have an issue. So we need to get over our issue, I think is the bottom line.
Wonderful, thank you. Actually, I'm sort of looking here at what's coming in, and someone has said, touching on that difference between insulin naive and experienced patients, if you have a patient whose type 2 diabetes is being really well managed with a daily basal insulin, there's really good adherence and their glycemic control is great, would you be encouraging them to move to a once weekly insulin? I mean, if they're asking you, or if they're happy as they are, would you be happy to leave them as they are?
So my philosophy is that my job is to ensure that my patients know what's available, and then listen to their reaction and then guide accordingly. So I feel like I will always mention to them that there is a once weekly. And then they'll always ask, well, what's the difference? And I'll say I mean, you saw it in the clinical trials, there's really no efficacy difference. The difference is you get 1 shot instead of 7. And then it's sort of some of them will say, you know what, I'm doing fine. I'm fine with it. It's no big deal. There's no real advantage, so I'm not going to bother. For some people, it's a cost issue, right? So if they have coverage for the daily but not a weekly, then they'll stay with the daily. But then I feel like if I don't mention it and I make that decision on their behalf, it's probably not appropriate. So I will tell them that this is available, and I will be upfront about there's no additional benefit really. It's just once a week. And if you want to try it, we can try it. And if you don't, I'm happy to leave you where you're at. However, if they're on daily and not achieving target, and part of that reason is because they're not necessarily getting it in every single day, because that is real life, then I may push a little bit harder in terms of the convenience of the once a week.
Wonderful, thank you. That's a lovely and clear answer, and I think it's the conversation that needs to happen with patients, isn't it? So we have had some quite specific questions come in, so I really want to get to those. So someone has asked, have there been any drug interactions reported at all that need to be sort of worried about?
Yeah, that's a great question. No drug interactions in the sense of like the cytochrome P450 and drug metabolism, but they are insulins. So therefore, the potential for hypoglycemia is very real. And being aware of if they're also on sulfonylurea, what you're going to do with the sulfonylurea to try to minimize that hypoglycemia. But I'm not aware of any other specific drug interactions per se.
Lovely, thank you. And there's another question here, it's a very practical question, which is what we like, about storage of the drugs and in warm temperatures. And people are just saying, storage and does that have an effect?
Yeah, it's great question. So the pen device that you're using can be left at room temperature, just like we're used to with the daily basal insulins, but the shelf life, if you will, at room temperature is considerably longer, allowing for people to usually finish the pen. Depending on your country, it's going to be supplied in different ways. So in Canada, we have insulin icodec, we only have icodec, in 2 different size pens. So depending on the dose of insulin that they're on, I will choose to give them the smaller volume pen or the larger volume pen so that we don't waste insulin, because there is a number of days that it's a good out. I can't remember the numbers of days now, but it's usually enough in order to finish the pen. Now, in very warm, it's the same issue. It's still a biologic. It's still insulin. And if it was left in a hot car in the summer here, it's still going to have a problem. So room temperature is still where it should be left, or the fridge. So refrigerator or room temperature.
Wonderful, thank you. And I'm just having a little look through here because they're all coming in now. So someone's actually gone back and asked a question about trials and saying, did the trials investigate individuals receiving intensified conventional insulin therapy?
Yes, so I can't remember the number. I'm going to say Onwards 4 and Quint 3. 1, 2, 3, 4. Quint 4, I think. Onwards 4 and Quint 4, I think, were the 2 that involved people on basal bolus, so basal bolus regimens. And as expected, in both of the studies, there was more hypoglycemia experienced overall because you've got bolus insulin in play. However, between the 2 basal insulin groups, weekly, daily, there was no difference in hypoglycemia, as well as efficacy. So equally efficacious and similar clinically meaningful or severe hypoglycemia. So yes, even in those on basal bolus, it has been studied, there will be more hypoglycemia because of the bolus and not so much the basal contribution.
Wonderful, thank you. So I'm looking here, just jumping between the questions, there are lots coming in. So someone's asked about the cost benefit aspect of changing from daily insulins to weekly insulins.
Yeah.
What would your answer be?
That will depend on obviously the country that you're in as to the cost. The way it's costed in Canada is the unit cost is the same as it is for insulin degludec. So it was not priced at a premium. You know, those decisions are beyond us. But if it's priced similarly to an existing second generation basal insulin, then that's quite favorable. Where there are savings then is in the needles, because there's less needles that people are needing to use. And then also in terms of waste of the actual pen device, because a device will last more weeks. And therefore you are saving, or the world, the environment is saving money, or saving something in terms of the actual waste as well.
Yeah, and you know that will matter to some patients too, won't it? They will be aware of that. Yeah, very much so. So I've had a question here about GLPs. Of course, we can't go far without talking about GLPs these days. So there was a question about combinations, because obviously patients are often on a GLP-1 and then they're going to be given an insulin. So one about actually combinations of the once weekly insulins with the GLP. And then another question about GLP specifically is, do you need any adjustments on starting and titrating icodec?
Okay, excellent. Yeah, so most people should already be on the GLP-1 when you're introducing the weekly basal insulin. So no, the GLP-1 does not need any adjusting when you introduce the insulin. It's the insulin that will be tweaked accordingly based on glycemic effect. And then in terms of, so is it safe to use the two of them separately in the same person? Absolutely. And then there's a fixed ratio combination, IcoSema. IcoSema is the one that is most studied. And I do not believe commercially available anywhere in the world yet, but I may be wrong. And it is a fixed ratio combination of icodec and semaglutide, both of which are once weekly administered injectables in the same device. And I have no experience clinically with IcoSema yet because it's not yet commercially available, but the clinical trials did show what you would expect, that you have the glycemic efficacy of an insulin as well as a GLP-1 and the benefits you would expect from that.
Fabulous, thank you. I can see our clock ticking away here as we come down to time. I wonder if I can sneak any more in. Sure. Just looking, someone has asked about how effective will it be if we get oral or non-injectable insulin? I'm presuming is that there'll be a comparison then about these once weekly injectables versus something that is, yeah, oral or non-injectable. Yeah. Do you have any thoughts on that?
So oral insulin has been something that's been worked on and talked about since the beginning of insulin, actually, since the beginning of use of insulin, I should say. When we get there, I think is that's probably a better time to be able to answer that question properly, because we will need to see how that oral insulin is delivered, what's that tolerability, how efficacious is it, all of those questions. I think and then other ways of delivering insulin, those are also still being looked at. What I'm really looking forward to in the future, though, are smart insulins. So glucose-sensitive insulins, I think, will be super cool, right? When you actually have an insulin that you can get into the body, which will work when it needs to and not when it doesn't. I think that will be very exciting. And so I think the insulin conversation will continue for decades to come.
Yeah, and I really look forward to seeing how it develops. I really do. It's so exciting. And I think this is such a major advance, and so great to see what comes next. So I think that as we're kind of at time now, this would be, you know, the past hour has just absolutely flown by. I think this is probably a really good time for us to bring things to a close. Thank you everyone for joining us today. I hope you've enjoyed the webinar as much as I have, and that you feel better equipped to embrace the once-weekly insulin therapies. Thank you so much, Dr. Cheng, for sharing your knowledge with everyone. I really appreciate you spending the time with us, and we're getting lots of lovely reactions from everybody, so I think everyone feels the same. So an on-demand recording of this webinar is going to be made available to you all within a couple of weeks, and it will also have a link list of all the papers that have been cited on the slides, and there'll be a copy of the transcript as well, and there will be subtitles put up, so lots of ways for you to enjoy it. And in the meantime, if you would like to stay up to date with Springer Medicine, please do sign up for our newsletters using the QR code that's shown on your screens now. And we look forward to welcoming you back another time. But until then, I wish everyone a wonderful rest of their day. Thank you, everybody. Thank you, Dr. Cheng.
Thanks, everyone. Bye-bye.